the goals of the presentation, what I hope to do over the next 45 minutes or so is to give an overview of the racial and ethnic differences in health. There are many ways to look at disparities in health in the United States, and this is one of the ways. This is one slice, and I'm going to focus on race and ethnicity. Review what are viewed to be the likely causes of the differences that we see. Sort of some about the recent trends and the differences that we see, and then talk a little bit about what we see as the future. First, let me talk about race and ethnicity as concepts in health research. I mean, there's been a continuing evolution really over the last 100 years or so of research on how you look at differences in populations defined by race or ethnicity. There's clear movement, and particularly over the last 20 or 30 years, away from race and ethnicities as sort of being thought of as proxies for genetics or biologic concepts. Clearly, race and ethnicity are social constructs. But there remain a fair amount of sort of uninformed pockets, even in the scientific community, who continue to think of race and ethnicity as being biologic or genetic proxies. And there might be components of biology and genetics that help separate groups, but really they really don't function well. These terms don't function well as proxies. Especially problematic in using these terms of race and ethnicity is that there's huge heterogeneity, and the term refers to variation within groups. So one of the themes I want to communicate is that although we talk about these broad categories of race and ethnicity in the United States, in fact, if you drill down into any group, you see huge variations across subgroups, even when the groups are clumped together. And that's another reason my use of these terms is problematic. I would argue, though, that these are still meaningful concepts because they still have great meaning in terms of how lives are lived in the United States now, and therefore might be very useful when we think about interventions. And as long as our society still has functional variations based on race and ethnicity, I think it's important to continue research in this area, but no, not everyone agrees with that. And I think there's really no firm consensus about what's the best way to use these concepts. But I'm going to forge on recognizing the limitations of these concepts. So why is this an issue? And probably the greatest and most compelling reason for thinking about this is what is sometimes referred to as the demographic imperative, which is sort of a nice way of saying that the composition of the country is really changing quickly. And many people believe, there's lots of predictions that by 2050, the country will be a majority-minority country, which is incredible implications for lots of ways in which our country functions, but particularly in health as well. So let me talk about what the differences are to start off with. And every now and then I'm reading something and I run across a line that just sticks in my mind. And this was one of those lines. This is from Juneteenth. This was the novel that was pieced together from the leftover writings of Ralph Ellison. And it's a great quote. One of the characters says, "Everybody goes when that wagon comes, Bliss. Babies and grandmas too, because there simply ain't no exceptions made. Death is like justice is supposed to be." And I would argue that even death isn't the way justice is supposed to be. And what we see is that depending on what group you're in might make a big difference in terms of the likelihood that you'll go as a baby or you'll go as a grandparent. And so this is a great summary of information about the patterns of health in the United States. This is life expectancy. I'm going to talk a lot about life expectancy and mortality rates. Life expectancy means sort of what's the likelihood of your length of life at the time you're born based on the patterns of death that we see. So in this case, a big number is better. You want to live as long as possible. Mortality is the rate at which people die. And there, obviously, a big number is bad. So life expectancy, big number good. Mortality, big number bad. And this is what this slide illustrates the last 100 years of mortality in this country. And I'll use my pointer here, if I can. And what you see is, I hope you can see, there are two big lines here. And what they show is a gradual trend up. And these are lines for white Americans and black Americans. We really didn't have good data on Hispanic Americans and other categories up until the last 20 or 30 years. We've only had data on the populations white and black since the turn of the century. And what's remarkable is that, one, life expectancy has increased tremendously over this period of time for everyone, almost everyone. So life expectancy for white Americans has increased by more than 60% over the last 100 years. Life expectancy for black Americans has more than doubled over this period of time. So that's one part of the story. The second part of the story is, in spite of those incredible advances, there remain persistent and large differences in health between these two groups and across many other groups in the United States. And that's really the core part of what I'm talking about here. So here we're talking about death rates, in which a larger number is bad. And you can see that the highest number at the top is black Americans, and then white Americans, then American Indians, and that's a complicated story, and then Hispanics, and then Asian and Pacific Islanders. That's the rating, the relative rates of health across those populations. And that's a complicated story to tell. It might seem simple, but it might not. It's really not intuitive in many ways. And I want to talk a little bit about why we see those differences, most notably why the mortality rate for African Americans in particular is so much higher than that for whites. Overall mortality is one way of looking at health. Another way of looking at it is looking just at the rate of deaths of infants. Infants are defined as those between birth and the first year of life, and our infant mortality rate is the likelihood of someone dying, really a marker of the likelihood of a child dying in the first year of life. It's thought to be a very good measure of social conditions in a society, the overall health of the population, and the fact is that, one, as the United States as a whole, we don't do too well when we are compared to many other countries, even some sort of middle-income countries. But more importantly, perhaps in this context, is that there are huge variations in the likelihood that a child will die in the first year of life across racial and ethnic groups. And that number, that bar that you see farthest to the right, that extends the farthest, that's the bar for African American babies. 13.35 per 1,000 live births. That's more than twice the rate of white babies, which is extraordinary, meaning the first year of life, a black child is more than 50% likely to die compared to a white child. And then we see lower rates. Hispanic rate is close to the white rate, a little bit less actually. Asians less. American Indians actually higher. So that's the all races, white, black, Hispanic, Asian, American Indian. So big differences in this marker, again, sort of following the pattern we see for overall mortality. Now let's drill down a bit. So I gave you the data on Hispanics as a whole, 5 deaths per 1,000 live births. Big variations when you look across Hispanic groups. Puerto Ricans, 8. On the other end, Central and South Americans, 4.5. So even though we talk about this pattern of Hispanic health, the fact is when you drill down, you're talking about very different groups. And in general, Puerto Rican health status are much worse than that of many other Hispanic groups. And there's lots of complicated reasons why that's true, but this sort of illustrates the caution that I raised at the beginning, that we talk about these large groups, when in fact, if you drill down in any group, you'll find subgroups that have much worse pattern and some that have much better pattern. Again, one measure of health status is simply amazing. It's simply asking people to rate your own health. Excellent, very good, good, fair, poor. Now you would think that this is sort of a crude measure of health status. It is crude, but it's amazingly predictive. Even if you control for everything you can possibly control for, smoking, all these other risk factors, the answer to that question is a predictor of your death. So each of you has in your mind some sense of your overall health. And that's a good general proxy for the quality of your life. So two big categories of measures of health status is one, whether you're alive or dead. The other is, what's the quality? It's the crudest is mortality. But then there are all sorts of differences, even if you're alive. And this gets at that. Again, this is a percentage of people who rate their health as fair or poor. So at the bottom, you have non-Hispanic black. Almost 15% rate their health as fair or poor. 8.5% for non-Hispanic whites, and Hispanics 12.7%. Again, a complicated pattern in lots of ways, blacks having worse health, both in terms of mortality and in terms of the quality of their life when you measure it by this proxy. Another drill down, you saw that the Asian percentage of fair poor health is 8.8% of the Asian population. When you drill down into subcategories of Asian populations, huge variations. The largest group having the worst health, among the worst health almost in every case, Vietnamese. 18.6% of Vietnamese reporting their health was fair or poor, compared to the other end, Japanese. Japanese Americans are among the healthiest people in the world. One of the highest life expectancy in the world are Japanese Americans. And this, again, this illustrates this notion that although we talk about these broad categories, when you drill down, especially in the Asian population, perhaps more so than any other population, you actually have huge variation, with some populations have extraordinarily good health and some having extraordinarily bad health, health that looks more like black Americans than like white Americans. But even within the black population, there's variation. This is, again, the percentage of people who rate their health as fair or poor, black, white, foreign-born black versus versus native-born black, foreign-born white versus native-born white. And you see this, again, huge difference. 20% of US-born blacks report their health as fair or poor, 12% of foreign-born blacks. So even within the black population, about 10% of the black population now, more than 10%, is of foreign extraction of some sort, either born in the United States or having at least one parent born outside the United States or having at least one parent born outside the United States. So even within this population that we're accustomed to thinking of in a very homogeneous way, there's actually great differences within the subgroups, and this is just one way of slicing that. So why do we see these extraordinary differences by race and ethnicity, huge differences in health in this country? This is one of my favorite slides. It's a New Yorker slide. And you have a middle-class black man being greeted at his door by the Grim Reaper, who says, "You'll be happy to know that race played no part in this decision." And this drives home the point that there truly is a New Yorker cartoon for every possible lecture. So what are the potential causes? And this is a simplification. I will grant you that, but it's a useful simplification. One, socioeconomic status, education, income, wealth, sort of economic position, social position. Health risk behaviors, smoking, drinking. Culture and acculturation correlates with lots of things like eating patterns and dietary patterns. Healthcare. It's the thing we talk most about, and that's good, but it's probably not the primary determinant of these differences that we see. Probably has a difference at the margin, not the big determinant. Biologic genetic factors, there are differences across populations. Environmental and occupational exposures, and psychosocial factors. And this is just one way of dividing up. There are other ways as well. Many of these are interrelated, and there's not a clear linear pathway from each to the outcome we see, because they interact among themselves, but it's a good way of sort of looking at the potential pathways. So let's start off with socioeconomic status and position. How is this usually measured? Education, educational attainment. Without a doubt, one of the strongest predictors of health status anywhere, in any culture. Economic status, income, wealth. Again, huge differences in the United States, so I'll talk a little bit about that. And it's not just your ability to buy good health. There are other things that correlate with that. Occupation, in the early studies looking at social class and health, a lot of it took place in the UK, and a lot of the studies looked at occupational status, because in that society, that was a much better predictor of sort of ranking. And broad social class and position, which correlates with the others, but isn't necessarily the same thing. And why does this matter? It matters because there are huge differences by these measures across these groups. These are data which may be hard to see, but again, the important point is income. These are income by race and ethnicity from the 60s through the 2008. The largest household income, median household income, Asian Americans. Below that, white, non-Hispanic, and then all races as a group, and then Hispanic, and then at the very bottom, black. So this suggests that, one, you know that economic status plays a role. You know that these groups have big differences in economic status. This might be one of the reasons why you see the differences that you see. And it's true, a big chunk of many of the differences that we see, particularly black-white differences, probably are related to economic status, meaning if you control for economic status, the difference gets substantially reduced. But there are some real anomalies. Now, this might seem like a very complicated, boring slide, but it actually tells an extraordinary story. This is infant mortality, first by race and ethnicity. Each of the little bars, the yellow bar is non-Hispanic white women, the sort of next pinkish bar is non-Hispanic black, and the bluish bar is Hispanic people. So these are infant mortality rates stratified by the education of the mother. So a mother who has 16 or more years of education, 13 to 15 years, 12 years, 9 to 11, or 0 to 8. So if you look across this, let's look at the yellow line. Clearly, the highest for whites, the highest infant mortality rate for mothers who have 0 to 8 years of education. At 10, the lowest, those who have college education or more. Sort of intuitively makes sense. For African Americans, a similar pattern. The highest mortality rates for infants are those born to mothers who have least education, the lowest, those born to mothers who have the greatest education. Not as striking, but still there for Hispanic mothers. What's notable here, though, is that the infant mortality rate for white women with 0 to 8 years of education is about equal to the infant mortality rate for black women who have a college education. I mean, this is extraordinary. Why do this makes no sense. And we can't, and there's still major questions about why this is true. But again, this just shows you that even in an area where we think it sort of intuitively sort of makes sense and we're pretty much explaining it, you see patterns like this that sort of defy easy explanation. And the high rate of infant mortality, even among very well-educated black women, continues to be a puzzling question in epidemiology. There are lots of hypotheses, still questions to be worked out. This looks at men, first white men, then black men, and then Hispanic men, and we stratify by whether they're poor, the purple, the lightest purple, near poor, middle income, high income. And again, within each racial group, you see this pattern that the higher income, the lower the percentage of people who report their health status as fair or poor. Again, getting at this notion that probably social class, economic status plays a role because they explain part of what we see. So that's a tiny slice of the huge body of literature on this. Let me try to summarize. The amount of difference that socioeconomic status plays in explaining the difference is determined by what you're looking at. When we look at overall mortality and many big, broad measures of health status, when you control for economic status, it explains a lot of the racial differences that we see, particularly the black-white difference. A lot of that is driven by social class. But you can look at other areas like infant mortality where you don't see a lot of it being explained. So again, a large percentage of the black-white differential in adult mortality and these broad measures of health, lived health, like these self-reported measures, is explained by economic status and other measures like that. Less clear for infant mortality, very confusing for Hispanic health. And let me talk a little bit about this. I presented this slide earlier, and my guess is if we had asked all the people in this room to rank if you look at Asians, whites, Hispanics, and blacks, if you ranked who had the worst health, my guess is that most would predict that Hispanics would have bad health by mortality because they're low educational attainment, low income, and those are usual predictors of health status. Amazingly, the Hispanic mortality rate is actually lower than that of whites. Now, this is called the so-called Hispanic or epidemiologic paradox. You know, when scientists don't understand something, you had to have a clever title. And this is the paradox, which means we don't know what's going on. And it's largely about Mexican Americans. The difference is largely Mexican Americans. So why do we see this? One, some have speculated that it's an artifact, that for some reason and there are complicated reasons why race and ethnicity information on death certificates is different from the census data that we base mortality rates on. Death certificates, who gives the race and ethnicity? It's either the doctor or the funeral home, and they often get it wrong. And they get it wrong in a systematic way. So there might be some artifact or misclassification. In reality, we looked at that, not the case. This is a real difference. There may be artifact, but it's not explaining this. Others are so-called really interesting sort of healthy migrant and salmon bias effects. Again, clever titles. The healthy migrant gets at this notion that if you're well enough to get on a plane and walk up the steps and carry your bag and get off that plane or get on a train or walk or get on a boat, then you're on average healthier than the whole population of your community. If you're really sick, you can't get on the plane. So the people who are leaving are differentially healthy, are more healthy than the people they're leaving behind, simply because it's a filter of health just to move. And that's the healthy migrant effect. It's actually been shown in lots of different societies, lots of different contexts. It sort of makes sense. At Ellis Island, there was explicit filtering based on health status. If you were in poor health, you were sent back or detained. So some of this is actually an actual filter to keep out unhealthy people over time. The salmon bias effect it refers to the pattern of salmon who swim upstream from saltwater to freshwater to spawn and sometimes to die. And the notion here is that when you're ready to die, you go back home. You go back home to your native country. Again, a clever title, not explaining what happens. It is true to a degree it happens, but it's not explaining the difference that we see here. And finally, the broad category of social and cultural factors. The speculation that in these Hispanic immigrant communities, they're very tight. They're sort of is a protective, large extended family network that ends up supporting health in some way. This is sort of, to be honest, it's just a catch-all group, and we don't know what's going on in reality. In spite of a lot of research to try to explain this, we still don't know what's going on, but it's true. Now the problem is, and I'll get to this, their children are in much worse health, and that's a problem. So let's look at the second category, health risk behaviors. You see lots of differences. This is just for women, data from 2005 to 2007, white, black, Hispanic, current smokers, heavy drinkers, leisure time, inactivity. Part of the message here is, again, there's a sense that minorities have bad health habits across the board. And actually, black women are less likely to be current smokers, less likely to be heavy drinkers, more likely to be inactive. But again, you have to look, the facts matter. And although there are differences, and we see differences like this, they aren't always in the direction where you would think. Overall, again, there's lots of research on this. There are clearly racial and ethnic differences in patterns of health risk behaviors. They're closely connected to other factors like educational status, clearly. But these differences probably account for some of the differences that we see in these categories. One sort of relatively crude study suggested that maybe even up to a third of the differences that we see were due to differences in these health risk behaviors, and that was driving the differences. So let's move to the next topic, culture/acculturation. And this gets at this interesting finding that when immigrants come to the United States, the longer they live in the United States, the worse their health gets. And this is an interesting study from a San Antonio Heart Study, a famous study. This is from the 90s, men and women. And if you look at these first two bars, the red bar and the blue bar, you see that for men and for women, the foreign-born Mexicans have lower mortality rates than the US-born Mexicans. And although it's not as striking in women, it's still there, and it's very striking in men. And this slide actually presents an even more interesting finding. This is infant mortality again. The likelihood of dying in the first year of life per 1,000 live births. Almost for every group, if you divide by whether or not they were born in the United States or foreign, the US-born have a higher infant mortality rate than the foreign-born. And what many people believe is happening is that as these communities, they come, there's a filter that makes them relatively healthier, and then as they acculturate, they pick up the worst habits of the American culture. The dietary patterns change, obesity rates go up, huge differences in smoking, particularly among women. Many immigrant communities in their native countries, strong cultural opposition to women smoking, and then they come to the United States and pick up the smoking habit. But we see this in lots of different settings. And it's very clear that a lot of health habits worsen as immigrants acculturate into the American culture. Smoking, alcohol, dietary patterns, huge increases in rates of obesity, risk factors for low birth weight infants, breastfeeding, and raises a lot of fundamental questions about our culture. But it's clear that this is part of what's going on. And as our current immigrant population acculturates and their children acculturate, this suggests that we're going to have huge problems down the road, given the size of our population that's immigrant. And one friend refers to this as sort of epidemiologic levitation, where the parents are sort of just look healthier, but their children are going to have much worse health than they had because they are acculturating and picking up bad habits. And our mortality rates and health numbers look sort of almost inappropriately good for that population. And then when we see their kids coming on board, they're going to have a much worsening pattern of health status. Lots of issues in terms of, there's lots of questions about how you measure acculturation. We don't even really understand the process itself. It varies tremendously. Some people don't even like the term acculturation. We actually don't know in great detail what's happening, and therefore there are limited opportunities still to avert these changes in behavior that happen as immigrant populations acculturate. Healthcare, I'm not going to spend a lot of time here. This slide didn't work well. The bottom line here is that there are significant differences across populations by race and ethnicity in the likelihood of being uninsured. And across racial groups, blacks are more likely, Hispanics are much more likely to be uninsured. And that's been seen for some time. It's related to the pattern of the jobs, differences in job patterns, because health insurance continues to be closely tied to your job. But other factors as well, mobility, tenure in a job, lots of other factors, but there are huge differences in the rate of uninsurance. And there's lots of study devoted to these differences in healthcare patterns that we see. We see these differences in uninsurance and not having insurance. We also see differences when we look at many measures of access to healthcare. Some of the most troubling studies that came out in the last about 10 or 15 years ago, were the studies that show big differences in the rates of utilization of certain types of medical procedures by race and ethnicity in ways that weren't explained by how wealthy a person was or how educated or his or her insurance pattern. Clear evidence that somehow in a systematic way, once individuals got into a healthcare system, there were patterns of differential treatment. Now, not explicit discrimination, probably, although there may have been some of that. Most of this was, I think, much more subtle, resulting in these big differences in the likelihood of getting certain procedures based on whether or not you were in a racial or ethnic group. And this has been a troubling concern. Many healthcare providers just viscerally react to this evidence because they feel that their own integrity is being attacked. And it's much more subtle than that. It always makes me suggesting that there's a large number of KKK members in the medical profession. We're not saying that. It's much more subtle. And there are more systematic types of ways that result in these differences that we see. They're probably almost certainly related to differences in health outcomes. While we have a fair amount of wasted use of healthcare in this country, some of it, a good chunk of it, actually has an impact on health outcomes. And it almost certainly plays some role in explaining some of the differences that we see, probably not a huge role. Biology and genetic factors, for a long time, it was difficult even to put this on the list because there was such visceral reaction to this notion that biologic or genetic differences might explain some of the patterns that we see. And I think part of that resulted from simplistic ways of looking at biologic and genetic differences and to be honest, sort of inappropriate ways in the past that the medical profession and medical research enterprise had looked at these issues. I think we're getting much more sophisticated these days. So this is just a study that was 2002, just the title of it, Ethnic Differences in the Frequency of Prostate Cancer Susceptibility Alleles. So this is a good example, not the idea that certain alleles are certain versions of genes, not the idea that one racial group had a gene and another group did not. That's actually relatively rare. What we do see is subtle differences in the likelihood, the probability distribution of certain alleles across groups. And it may be that just having a particular allele that's more likely to be associated with prostate cancer is at a slightly higher rate is enough to potentially explain some of the differences that we see in outcomes. Prostate cancer is particularly noteworthy because African American men have among the highest rates of prostate cancer in the world. It's also less than the rates, by all measures, of prostate cancer of black men in Africa. It's something about the interaction of the group here in the United States that results in this dramatically higher rate of prostate cancer. And we are beginning to see studies that are beginning to tease out whether or not some of that might be related to subtle differences in the distribution of certain versions of genes that carry with them higher risk for cancer. So it is likely that differences in the prevalence of certain types of genes may explain some of the differences that we see. There are clearly a growing number of studies, many funded by the NIH, that are beginning to get large populations in which you also have genetic information, and you can begin to tease out the extent to which these genetic factors might play a role. It's clear that simplistic models are not likely to explain some of the recent trends that we've seen. So, for example, the huge increases in the rates of obesity and the particularly higher rates among blacks and Hispanics, the genetic composition of the population does not change over the period that we've seen these differences. So while genes might explain which people within each of those groups are getting it, are becoming obese, it's unlikely to explain these trends because genetic composition of populations doesn't shift that quickly. But it might explain some of what we're seeing. And fortunately, I think there's more and more sophisticated research trying to drill down and to tease out these different causes, and that's a good thing, I believe. Environment, this is an interesting slide. Each of these bars compares whites and blacks. The white bar is whites, the black bar is blacks, in a percentage of the population living within a mile of a polluting industrial facility. And then it's stratified by geographic region. And you see that African Americans are substantially more likely to live within a mile of a polluting facility. And you see these differences across groups, and it might be notable that group with the big difference is Midwest Metro. So I think that's Chicago and other urban areas of the Midwest where the difference is perhaps the greatest. Now, you can think in simplistic ways about this. It's actually a complicated picture to try to tease out what's happening here. And there are lots of theories, but there's a fair amount of evidence, and the whole field of environmental justice really is focused on these types of findings. And it's clear that African Americans and Hispanics in particular more likely to be exposed to environmental hazards, more likely to work in high-risk occupations, and to have higher occupational fatalities. There are actually few data sources sort of linking both the environmental exposure with the outcome. You need sort of clean longitudinal cohort data sets, and we actually don't have many like that. And it's unclear how much these differences explain the big differences that we see, but again, they probably play a role. How much of a role, we don't know. Finally, psychosocial factors. I won't present any evidence here. There's lots of literature focusing on psychosocial factors, particularly stress and discrimination and reaction to discrimination, much of it early on in looking at hypertension. And there are relatively few longitudinal studies linking all these patterns. We're looking at stress factors of various sorts, a reaction to stress, and seeing whether the reaction to stress and the sustained nature of stress might play a role in explaining some of the differences in particularly big diseases where there are big differences in outcomes like hypertension. We're getting better and better data. There is something here. How much, we don't really know, but we're getting better and better data, and I predict over the next 10 or 15 years we'll have more information about the extent to which we actually know how much these differences in stress, particularly sustained stress, might have in playing a role in explaining the differences in outcomes like mortality. So summary, there are large differences in health across subgroups. I think this has major implications for the health of this country as a whole, given the dramatic demographic shifts that we're seeing. The causes are complex. Many are rooted in social and behavioral factors, and we need to be very honest from the beginning. There will be no quick and easy and simple either explanations or fixes. I went to a great talk once by a speaker who was talking about this, and she was great. She said, dealing with these problems is like dancing with a bear. You can't get tired. You can't sit down when you get tired. You have to wait for the bear to get tired. And this is sort of what we're talking about here. We're going to be dancing with this bear for a long, long time. There isn't going to be a quick and easy fix. There are papers from the 30s and the teens in public health journals trying to predict how long it would take to begin to see narrowing in these differences that we're seeing. The first were very predictive of narrowing of the differences quickly. By the 30s, the Public Health Service and other professors were saying, this is going to be a long haul thing. My guess is they didn't think it was going to be this long of a haul, but it was going to be a long haul. So has there been progress? There's been a lot of increasing attention to this issue, particularly over the last decade. During the Clinton administration, there was a President's initiative on race that focused on eliminating racial and ethnic disparities by 2010. We're here. These were the areas that were the areas of focus. And this was a smart strategy in that there was a focus on particular outcomes. I must admit, within the scientific community in particular, there was a great debate about whether or not this was reasonable. And was, in fact, actually, I wouldn't say that. There were those who said it was laughable that we might actually try to eliminate these differences in 10 years, and it was totally inconceivable that we would do it, and it actually took away from the objective when they weren't being realistic. Others, including those who pushed this, really want to drive home the message that we think we can actually narrow the difference. We're a long way from eliminating the differences. In mortality trends, we've actually, when you look at the last 100 years, there have been periods when the differential between blacks and whites, and again, those are two populations we've had the best data on for the longest period of time. There have been periods when the differential narrowed, periods when the differential increased. There was a big increase in the black-white mortality gap, so blacks having much higher mortality rate than whites in the 80s. Much of that was related to HIV, AIDS, and cardiovascular disease. Those gaps decreased in the 90s. For males, it was related to drops in homicide rates and HIV and unintentional injuries, and there are complicated reasons for that. Progress in heart disease in women. So we had some improvement of the gap in mortality. But when you look at specific diseases, it's all over the map. And for some diseases, you have the differential widening. In other diseases, you have the differential narrowing. No short, simple story. What is very clear, though, is that we haven't had huge gains in the disparities for infant mortality. And again, this is the crudest measure of the well-being of society, and we do really poorly as a society on this measure. And there might even have been some increases for the differential for African Americans. In terms of health access, I think many of us expect to see some reduction in the disparity with the implementation of healthcare reform. We will see. We'll see whether it's implemented, actually. But clearly, with the expansion of health insurance coverage, any expansion of health insurance coverage will help promote narrowing of the access gap. It's really difficult to guess how much. The federal government has a system called the Healthy People Objectives. Every 10 years, we set objectives. It's a massive book that comes out, where it began in, I believe, in the 1980s, when the government said, we're going to start setting explicit objectives in health for the country. And then when the Clinton administration began to focus on the disparities, there were specific pushes to try to narrow the gaps in some of these outcome measures. When you look at the data for some of these measures and compare 98 to 2006, there were 6 indicators where there were narrowing of disparities, and these were not just black-white disparities, Asian-white, Hispanic-Asian. There were a range of different disparities. Some indicators had decreased disparities, others had increased disparities. Again, there's lots going on. Some things seem to be going in the right direction. Many others are going in the wrong direction. So why have we seen these only modest improvements after over 10 years of really focusing on this? Some would question whether we've really focused on it, but we've had focus. The bottom line is that the causal pathways and the factors are deeply embedded in social institutions in structures that don't change quickly, and that's the bottom line. We have increasing evidence that early and even prenatal factors set people on trajectories of health that might not even be apparent, a differential might not be apparent even until middle age or late life for something that happened before birth, intrauterine. And there's actually a really fascinating amount of literature, growing literature that I find compelling, that the intrauterine environment, differences in the intrauterine environment, clearly sort of seem to be correlated with differences way out in life. There's a British researcher by the name of Barker the hypothesis is actually named after him, the Barker hypothesis. Another important recognition is that these causal factors accumulate. So by the time you see a difference in someone who's 50 years old, it may reflect a difference in the causal pathway that's been in place for 40 years. And the notion that you're going to turn those numbers around in 10 years is incredible when you look at actually the causal pathways. It's going to take a lot longer time for us to figure out what's going on. I would argue that there's also been a fair amount of intellectual leadership, a lack of intellectual leadership, both within the scientific community, much of which still dismisses some of this research as sort of being political or social do-good research and not really important research, and political leadership more generally. Now, we can talk about that. I can say that now that I'm no longer in the federal government. So where do we go from here? I think we have to commit to long-term, realistic strategies. We have to try to identify low-hanging fruit interventions where we might have a credible task. Vaccination is one area where there's been a fair amount of progress, and that's great. We need to exploit opportunities to use non-health domestic policies, education policies, and others to try to reduce disparities. I think we need to thoughtfully deploy targeted disparities where we look at an intervention that's specifically designed to narrow a disparity in a particular across a particular population or a particular disease. And there might be some of those that can be done at a relatively low cost. We need a better understanding of causal pathways, of course. I'm a researcher, I'm going to say that. We need to have better understanding. And I think we need serious leadership focusing on the opportunity to change the status quo. This is my worst case scenario about what I am concerned will happen in the future. I think that there's increasing evidence that the medical knowledge that we're advancing, that's advancing at an incredible clip, will actually result in really stupendous advances in our ability to intervene and improve health in the future. The problem is that when in the past we've seen a remarkable differential rate at which advances flow out to populations based on where you are in society. And this is an interesting table that is a crude table but an instructive one. This is the median age at death for persons with Down syndrome by race from 1968 to 1997. Now, over that period of time, there was no cure for Down syndrome. There was no cure. There were lots of marginal advances where we got better and better at identifying problems, cardiovascular disease, intervening, and really trying to use what knowledge we had to improve the health status of these children. When we look at the 1968, the average age at death was less than 5 years for everyone. And then as you saw advances being made in understanding what needed to be done, you start to see this huge variation. So by the time we reached 1996, the white kids, individuals with Down syndrome, were dying in their 40s, blacks in their teens. And what was clearly happening, I believe, is that, again, this reflected the differential rate in which this knowledge was diffusing out to different populations, and ironically, an advance in knowledge actually worsened the disparity. Some got a lot better, and some didn't get better at all, so the difference started increasing. This is an extreme example. I think it's unlikely to be seen across major causes of death, but it's an important example and something to think about as we get better and better interventions that we think are effective in narrowing the gap and addressing healthcare problems in general. And so special thanks to my colleagues at the National Center for Health Statistics and at NIH and a student at Grinnell who actually helped put this in a form of where Grinnell was on every slide. And that's my job now, is to have Grinnell on every slide. And I'll end there. And I'm happy to take questions. I'm a few minutes above my time, but we can have 10 minutes at least of questions.
Yes, recent research seems to indicate that some of the factors that cause health problems like smoking, obesity, and so forth affect the genetic switches that affect the expression of genes, and that is inherited, can be inherited. I guess it's been shown up to 4 generations in rats. Now, how does that going to affect
Well, again, that's more likely to determine which people get it. So it's important to distinguish between differences when you're explaining individual differences versus population differences. So for that to play a role, you'd have to have a difference in distribution of those factors that are switched on or off across the population. And that's where some of the research in genetic patterns is beginning to drill down to when we get a knowledge about a particular causal pathway. And there are lots of these where we're seeing really complicated patterns, particularly the chronic diseases, where lots of genes are in play and genes are turned on and off at different times, and all that leads to the disease that we see. We have to drill down and start to see whether there are differences in the distribution of those versions of genes by race and ethnicity. And that's how it could explain a pathway like that, could explain what's going on. But again, it's unlikely that we're going to see complete separation of populations in terms of differential distribution of some alleles. It's unlikely that we're going to see a pattern like sickle cell disease, and even there, it's not as absolute as people like to believe, but it's not going to be like that, where you have a huge prevalence in a population and then nothing in the next population. What we're going to see is overlapping distributions where the probability of having a particular version of a gene might be higher in that population, and then the environmental factors that might turn on or off that gene might also be different in that population. So it's a complicated causal pathway, and we're going to have really complicated, really thorough databases to try to drill down and march through these causal pathways. And we like to believe that knowing those causal pathways will actually help us do a better job in intervening in some way. Others?
Dr. Kington, thank you very much for a wonderful talk. I'm up in the balcony. I got the next question.
You threw me there.
Wonderful talk, thank you. Many of us believe in and work for single-payer healthcare, and it is about everyone having access to healthcare. It's also about a commitment to social solidarity and social justice, and about a transfer of wealth from the rich to the poor, because the rich would pay more, the poor would get the care that they need. Can you speculate on what effect that would have on disparities in health outcomes? Thank you.
Again, my answer is really different now. I can answer the question to some degree. It depends. I mean, clearly anything that levels the playing field in terms of access to health care across populations will help us to the extent that differences in access are a causal pathway. And I think there's compelling evidence that some of the difference that we see is related to differences in access. I think as science gets better and our ability to intervene gets better, these differences will probably be even more important. The question of how you get there is a more complicated question. The political strategy to get to comprehensive coverage is a different question that I'm probably not very qualified to answer. But you're right, to the extent that any strategy narrows differences in access to health care, again, to the degree that what we do in healthcare will have more and more impact on your actual health, then that's a good thing in terms of narrowing differentials in outcomes. So, does that make sense? I try not to use too much jargon here. Yes, and then I have to go with the person who has the microphone.
Have you looked in the data at the factor of marriage, family, complete family units versus not?
Well, there are big differences in the familial structures in all sorts of ways. And again, I don't know of the data. Actually, I don't know of the data linking the differences in family structure patterns with specific sort of measures of overall differences in health status. You could speculate, there's lots of speculation that and compelling evidence that people who have more comprehensive social networks of all sorts do better in terms of health. And there are these differences in social networks across groups. Some minority groups actually have stronger social networks than majority population. But I don't know of evidence that's linked that in a substantive way to differences that we see in terms of health. It's an intriguing question.
Okay, I'm going to not use my
For John.
Two questions. One is, when you did your analysis, did you look at age of the mother in relation to... Did you look at age of the mother in relation to infant mortality?
The studies that have looked at these differences have looked at almost all of the known factors. I mean, including age of mother. I mean, there's a pretty significant, huge body of literature on this,
Right.
where because it's such an extraordinary finding. And while and some of the usual suspects like education and age of the mother and family support and access to health care and prenatal care and all those things might explain some, doesn't explain the difference that we see.
Okay.
So-
And just one other question is, NPR just recently did I thought a great program on disparity in cancer outcomes in Chicago, and how with the African American population, the white population, it has gotten worse over time. And the two factors that they talked about were obviously access to health care, and then the other one was, it was a cultural factor about how African Americans tend not to get screening tests and that sort of thing. So I was wondering if you could talk about how that might be rectified, because it's not so much an access issue.
Well, I mean, there are huge differences by both race and ethnicity, and lots of other ways of cutting up society in terms of willingness to get screening. I mean, it's a big issue. And there's lots of socioeconomic factors that explain part of that. And I think that, that certainly is a reasonable strategy. And there's a fair amount of interventions now. For example, one that I was just reading about, where the intervention was about going into black barbershops to get African American men to get screened. And so there are really, I think there are lots of, I was participating in research in Los Angeles that was using social networks within churches to get African American women to get breast cancer screening. And so there's more and more sort of interventions like that, some of which have shown to be effective. In my mind, the question is sort of how do you translate that in a major way to sort of fundamentally change a culture, which is much more complicated, as you can imagine. So yeah, we'll have interventions, but you know what? Realistically, we're not going to be able to fund hundreds and thousands of these little micro interventions. And I wonder whether or not we have to think about intervening at a much higher level in the social structure. And that is harder to do and harder to study, and a more difficult challenge. But while I think we'll see more and more of these interventions showing an impact, showing various ways you can intervene through non-traditional pathways to change the sort of cultural milieu of a community, I don't think that's going to be the answer. What that shows is that you can change through that pathway. I think we're going to have to look at much higher scales realistically. To do those interventions on a massive scale, it's just not feasible, I believe. That's my prediction, my sense. So then it's about changing at a much higher level, and that's harder to do, harder to study, harder to implement, but in the end may be more effective. Sort of, it's a stigma. So look what we had to do to change the smoking pattern in the United States. So we had dramatic change. We still have 20% or so of the population smoking, but it took taxes and stigma and changing laws about smoking and evidence about exposure to children. I mean, sort of all of these different interventions at every level of society to get where we are, and we're still not at zero. I mean, so this is going to be a long dance. I can assure you. Yes.
You showed near the beginning, Dr. Kington, thanks for a great talk,
Sure.
that extraordinary slide of the increase in life expectancy in the century. I mean, life expectancy doubling for African Americans and increasing by 25 years for whites. And you also, in that same slide, were able to highlight the lack of decrease in the disparity problem. If you had just a fixed amount of money to spend, and you could fix one of those two curves, that is, you could keep the curve going up in parallel fashion so that life expectancy for everybody kept going up, or alternatively, perhaps sacrificing that persistent rise to resolve the disparity question. How do you even deal with it?
That's a great question. So when you say that, it usually means you got to think of an answer. You're still thinking of the answer to that. I personally believe that the answer is going to be that we're going to see when we see dramatic difference narrowing, it will not be due to primarily interventions that were targeted at narrowing a gap. It'll be interventions that were fundamental advances in the knowledge for everyone, and then while with some lag, everyone will benefit from it. And that's not to say that I don't think we need to have targeted research to look at causal pathways and pockets of difference and different ways of intervening through different pathways in different groups. We should. I just think that, if someone said, okay, where do you want to go to get the most effective bang for your buck in terms of narrowing? I would probably say, let's cure diabetes. Let's cure hypertension. Because those are the diseases where you have these huge differentials. Again, but that's not to say we shouldn't spend anything more. But if I were a benevolent dictator, I hope I would be benevolent, that's where I would go with the money. I'd try to get a cure for the big diseases where we know there are big differences, and the differences account for the differences in mortality that we see, and then work really hard at diffusing the advances more rapidly across all populations, and that's a trickier question.
Up in the balcony.
Ladies and gentlemen, we have time for just one more question.
Then it's the balcony question.
I feel bad now.
It better be a good question.
Maybe we should give one more. I was just asking something about the data acquisition, and it really has been in my mind about the Hispanic paradox. And how are you getting these data sets? Is it from census data? Is it from something like that? Because I feel like illegal immigrants who may give us the impression that they would have a lower health rate might not be included, because I saw you had non-white Hispanic, and then in another slide you had Mexican Americans.
Yeah, this gets at sort of whether there are artifacts in the data somehow. First of all, we're not talking about self-reports of health status, we're talking about death. So there's a body. I mean, sort of we know that someone has died. The question is what group the person is in and what was the denominator. So the denominator comes from census data. Census data is self-reported data. The numerator comes from death certificate data, which generally comes from either the physician or the funeral home director, and they, in a systematic way, misallocate, particularly Hispanics, Asians, and mixed race people in particular. America's had a lot of practice with the black categorization, so less of a problem there. And so there are differentials, but we even see it when we look at longitudinal data sets when we've asked individuals to self-identify. It's probably the best source, and it appears to be truthful, and then you follow that cohort based on self-report and see who dies. And even when you look at that, you see these differences, which tells us it's not just a data artifact. There might be data artifact in gross mortality statistics, but if that's the problem, then you shouldn't see it in the longitudinal data sets where you ask people data at baseline and follow them over the course of their lives 20, 30 years to see who lives and dies and when. So nice try, still a big problem to try to figure out. Thank you.